My name is Dr. Clement Muka. Today, I'm going to be doing a response actually. It's a response to what my prof had. He actually overheard in a restaurant. He overheard a man saying, with all the eloquence and the flamboyancy, saying, I have abandoned all my household chores because I've been diagnosed with a systolic murmur. I'm taking it easy, guys. I'm taking it easy. What I normally do, I don't do at all. I'm taking it easy. I'm taking it easy. This is a response to that. My prof said, Clement, do something. Say something about a murmur. Well, first of all, he says to me, there are two types of murmurs. One group is called innocent murmurs, functional murmurs, which have no clinical significance. They don't kill anyone. The other group is that group of pathological murmurs. This one is of clinical significance. A healthcare worker has got to do something about it. It has got to be reported to the specialist and all that. But what is a murmur in general? A prerequisite of a murmur is turbulence, blood flow turbulence. And then this will result in auditory vibrations of cardiac structures. Cardiac structures I'm thinking about is a valves that I have in mind. There's an inlet valve known as the mitral valve, an outlet valve known as the aortic valve, an inlet valve on the right, tricuspid valve, and on the right, the pulmonic valve. So those are the cardiac structures we're worried about. And of course, the blood vessels coming from those. We say if there's auditory vibrations of these cardiac structures because of turbulence, blood flow turbulence, that will give rise to a murmur. But now, we need to know. We say %90 of systolic murmurs, 90%, they are innocent murmurs, no clinical significance. Functional murmurs, no clinical significance. That's the same thing. That's the same group. It's just another description. Functional, innocent murmurs. They're innocent in the sense that they don't cause any problem. They don't cause any disease. But the 10% are pathologic murmurs. Now, here, our case is simplified. We are told already that this is a systolic murmur. So this is one part of the cardiac cycle. The cardiac cycle consists of two phases, the contraction phase and the relaxation phase. The contraction phase is given a special name. We call it the systole. And the relaxation phase is called the diastole. So all members coming from the relaxation phase, if you can hear them, because very difficult to hear, very, very difficult to hear. If you can hear them, then they are pathologic. All diastolic members are pathologic. But 90% of systolic members are innocent, not disease causing, of no clinical significance. These, the systolic, we need to talk about them. We need to know whether we're reacting from a statement. The Prof says, this man, a very eloquent speaker, he had a group of guys and he was talking to them and he was the main speaker. And he says, guys, I'm not even going to take these dishes. I'm taking it easy. I've abandoned all my household chores because I've been diagnosed with a systolic murmur. Now we don't know this murmur, whether it belongs to that 10% that is pathologic murmurs. Pathologic murmurs are disease causing. They are bad murmurs. So now we have to come to these systolic murmurs or contraction phase murmurs. Those are divided into two. We've got ejection murmurs and we have regurgitant murmurs. Ejection murmurs. So we are lucky here. We know already that we're dealing with systolic murmurs, but we don't know whether it is an ejection murmur or a regurgitation murmur. We don't know that. So what we need to do then now is to time the murmur. We already know the phase. That is a contraction phase. It is a systolic phase murmur. We know that. We know that. But we haven't timed it. We need to know whether it is early. We need to know whether it is mid-systole, early in systole, mid-systole, late systole, or right at the end. When we say early systole, early from, our meter stick is always S1. That is sound number 1. You know, there are hard sounds from S1, S2, S3, S4. Those are the hard sounds. S3 and S4, you hardly hear them. So the ones that we use is S1 and S2. So S1 is telling you about the mitral valve and the tricuspid valve. We say it's M1 for mitral valve. We say T1 for tricuspid valve. And that consists of S1. S1, that is what? That is sound number 1. So the murmur starts from S1 and it spans around up to S2. But when we're timing it, we want to know where is it exactly? Where's the murmur? Is it just early, just after S1? That's when it starts. And then if it's an ejection murmur, it has got an upward phase or an ascending phase known as the crescendo, and it goes to a peak and then it goes down. That is the decrescendo phase. So that's the shape. We always get this in an ejection phase or in an ejection fraction. We always get this crescendo, peak, then decrescendo. But we want to know where does that is the shape of the actual murmur. We want to know, does it start here? Where does it end? Does it end early in systole? That's very good. If we know that it ends early in systole, that is an innocent murmur. It's not going to do anything to my patient. If it starts in systole and it ends before S2, or it starts late in systole, if it starts late in systole, we know that it will get to S2. S2, what's S2? S2 is A2 and P2. What's aortic valve closure? P2, pulmonic valve closure. So that consists, those two, they make S2. And S2 is very important. It's a determining factor. It's a determining. If the murmur doesn't reach S2, that's powerful. That's good. That murmur will be an innocent murmur. It will not hurt the patient. But if it gets to S2, you must remember S2 is aortic valve closure. So if it disturbs that aortic valve, you must remember, that's the valve that is supposed to push everything to the aorta and to all the parts of the body. In other words, blood to all the parts of the body. Now, if anything disturbs A2, that's a problem. Because one thing will happen is either it will silence S2. And in silencing S2, it silences those two components, A2 and P2. And if it silences them, or it makes them to go right down, then this is a problem. It means it's interfering with the closure of the so the blood that's going to be pushed to all the parts, it's not going to be pushed effectively. So that's a problem. So S2 is a determining factor to say that we're getting into pathology now. We're getting into disease. We're getting into disease. So once S2 is disturbed, if S2 is not disturbed, then we're happy. Then we're talking a murmur that is innocent, a murmur that is functional, a functional murmur. And it's of no clinical significance, which is very good. I have an example for that. Where, for instance, aortic sclerosis. Aortic sclerosis is such a murmur. There will be turbulence because the calcific spares, they are protruding like that from the root of the aorta. They are protruding like that. So when blood is being pushed through these, it gets turbulence. So turbulence, remember, turbulence is the prerequisite for the formation of a what? Of a murmur. Of a murmur. A murmur, defining it as what? As an auditory vibrations of cardiac structures. So if there's auditory vibrations, that's a murmur. And it has been caused by the turbulence, which was caused by those spares, those calcific spares, which are protruding like that. And so blood goes through them, and then it causes the turbulence. So aortic sclerosis is actually of no clinical significance. It doesn't cause anybody to fall ill and all that, and have a pathology. So you never get that. So, but then as opposed to aortic stenosis, there's a big problem. Now, with aortic stenosis, there is turbulence, but the turbulence is such that it has got to go through an obstruction. There's an obstruction here. And so the blood has got to be pushed through an obstruction. And this is a problem. What we were talking about the timing of the murmur. The murmur that is generated here will have a special feature. It will actually, we call it a murmur of aortic stenosis. It will have a different picture than the murmur of aortic sclerosis. Murmur of aortic sclerosis had this one thing. It was not radiating to any structure. It was not moving from the aortic root and moving to any structure. But that one of aortic stenosis, it moves from the precordium, that is the chest, and it moves and it radiates to the neck. And this radiation to neck is a feature that tells you that this is pathologic. This is not something that you had before. You know, the murmurs are judged in the same way as we judge people. You know, I don't want my son to be going around with those naughty boys. So the company that my son keeps determines who he becomes. In other words, you know, we normally say a person is a product of his or her own environment. So if the murmur keeps bad company, abnormal pulse, for instance, that's bad company. Fever, that's bad company. We don't want that. So bad company determines what the murmur is going to be. Is it going to be a pathologic murmur, or is it going to be an innocent murmur? All innocent murmurs, they are not accompanied by bad company. They don't have bad company. If you were to do an ECG, for instance, you will not find problems like LVH, you know, left ventricular hypertrophy. That's bad company. You will not find that. Not with the innocent murmurs. Innocent murmurs are caused only by fluid, shall I say, the velocity of blood. The change in the velocity of blood, if it increases, it's going to generate a murmur. It's going to generate a murmur. For as long as there's turbulence is going to give rise to an auditory vibration of a cardiac structure. And an auditory vibration of a cardiac structure is what is known as a murmur. That's the definition of a murmur. That's what you're going to get. But then this murmur can either be functional, innocent, or it can be pathologic, disease causing. In other words, that's in that 10%, and that's a big problem. And that one has got to be reported to the specialist. That one has got to be, you know, there's no way that you can handle an aortic stenosis murmur. The other murmur, for instance, mitral regurgitation. Mitral regurgitation will radiate to the axilla. It will radiate to the axilla. And that radiation to the axilla is not something that you saw with innocent murmurs. There's no radiation at all. In fact, innocent murmurs, you can even make out that the murmur is innocent by asking the patient to inspirate. Inspiration, it goes quiet. Whereas a pathologic murmur would never go quiet with your inspiration. You know, if you are to move around, an innocent murmur is going to change. Stop, come back again. You know that, in other words, it's affected by motion, by changing position. A pathologic murmur will stay there. Doesn't matter what you do. In fact, with the S2 will have a fixed split. That's a pathologic murmur. A fixed split, S2. When you say split, you mean to say the separation between A2 and and P2. It will be fixed. Remember, S2 consists of what? A2 and P2. A2 being aortic valve, P being pulmonic valve. So this is the second heart sound. So there will be a fixed split, fixed. It will not change. It will not change at all. It will be fixed. Then you know that there's pathology here. You know here there's disease. This must be looked at by the specialist, the cardiologist, for instance. My prof, for instance, will have a look at that. And that's what I need to find out from the patient, because I'm the first contact with the patient. I see the patient, and I'm the one who's doing the ECGs. I'm the one who's doing this, the examination, physical examination, and all that. And with it, I have to ask the patient to take his hand to the precordium. Take it to the precordium, where the source of the murmur is. In other words, if it's in the apex, I put it there in the apex. Put it there. If there's rubbing against this, in other words, I can feel the murmur in my hand. On my hand, the palm of my hand, I can actually feel the murmur. Then we call that a trill, a precordial trill. It's a trill. It's a trill. If once you have a trill, you've already classified the murmur. You've already said, you've already classified the intensity of the murmur. That the intensity of the murmur is, when you classify murmurs, the intensity of the murmur, how loud it is and how soft it is. You use a scale of 1 to 6. You say 1/6 if it's lowest, 2/6 coming up, 3/6, 3/6 downwards. We say those murmurs are innocent. When you get to 4, 4/6, 5/6, all those murmurs are pathologic. So if you and all those murmurs above, if the loudness, the intensity of the murmur is, you can actually feel it with your hand. Feel it with your hand. In other words, there's a trill. There's a trill. If there's a trill, already you know that this is a pathologic murmur. And then this is the type of murmur that must be reported. So this is basically what the mitral regurgitation murmur will also amaze you. It will radiate to the axilla when it's so different from that one of the aortic stenosis. Aortic stenosis will radiate to the neck, and this is amazing. You will see it. A regurgitating murmur. Remember we said systolic murmurs are what? Ejection murmurs and regurgitating murmurs. And regurgitating murmurs, in fact, ejection murmurs are measured by what is known as, if you look at the pressure before a valve and you look at the pressure after the valve, the pressure is normally the same, and that's the normal. It's normally the same. In other words, before the valve and after the valve. Once there's an obstruction in the ventricle, a ventricular obstruction, there's going to be a build-up of the pressure before the valve. And the pressure after the valve is going to be at a low level. And the pressure before is going to be at a high level. After the valve, at a low level. This difference is called a pressure gradient. And it is a determining factor as to how loud the murmur is going to be. How loud is determined by the pressure. The higher the pressure gradient, the higher and this is disobeyed by only one thing. one condition will disobey this. In other words, this rule to say that the pressure gradient is a determinant of the loudness of the murmur. Yes, it does. It does. It is a determinant. The higher the pressure gradient, the higher the louder the murmur. And that is true. The intensity of the murmur is determined by the pressure gradient. But this is disobeyed by one condition, that is congestive cardiac failure. Congestive cardiac failure will disobey that because the congestive cardiac failure is determined by the reduction in the ventricular contraction. Reduction in the ventricular. So when the ventricular contraction is reduced, so it won't be able now. So it can't compete with the pressure gradient. It's not the pressure gradient that does the softness of the murmur. The softness of the murmur, what is responsible for the softness of the murmur is the fact that the heart is failing to pump. So it is the pumping ability of the heart that is now a determining factor as to the softness, to explain the softness. And this I would like just to say something, just to round it up. You know, there's a condition known as, there's a murmur referred to as the hypertrophic obstructive cardiomyopathy. This one is special. It's when the ventricles are normally separated by a septum. But now if this septum between the ventricles gets hypertrophied, it gets bigger and bigger and bigger. It affects now the mitral valve. When the mitral valve is supposed to close so that there can be pushing of blood to the aorta, so that there can be pushing of blood to all the parts of the body. This thick septum, this hypertrophic septum, it pulls the mitral valve open. It pulls it open. When it's supposed to be closed, it's pulled. So it opens to regurgitate. In other words, to go back. So now there are two outlets. There's a forward outlet and there's a backward outlet. So this is caused by, they call it HOCM, because it's hypertrophic obstructive cardiomyopathy. This hypertrophic obstructive cardiomyopathy causes that problem. In other words, it causes regurgitation of blood. It opens the mitral valve, so the blood regurgitates. Now there are two motions here. There's the forward motion, which is the normal motion, and there's the backward motion. And this is a problem because now you know, when we're using pressure gradient as a determining factor, when we're using pressure gradient as a determining factor, we know that when you use, the higher the pressure gradient, the louder the intensity, or the louder the murmur. The intensity of the murmur is loud because of a higher. But now, if there are two outlets, this is only when there's one outlet that the higher the pressure gradient, the higher the louder the murmur. That's when there's only one outlet. When there are two outlets, there's a big problem. The regurgitant murmur, because the ventricle has got two problems. has got two problems. He has got the forward motion and the backward motion. The intensity of the murmur doesn't increase at all. It doesn't matter what happens. It doesn't increase at all. The intensity of the murmur, it doesn't. That's one area in which you would see that this is a regurgitant murmur and this is an ejection murmur. With an ejection murmur, there will be an increase in the pressure gradient, and the pressure gradient will give rise to an increase in the loudness or the intensity of the, and that's basically what would happen. And this is you know, and what we need to know is that it's not only just the pressure gradient that is a determining factor as to how loud a murmur can be. For instance, the high output states like fever, like pregnancy, like thyrotoxicosis, like, you know, those are high output states. Because of that, you'll find that you'll find that there's murmur because of that, and the intensity of the murmur increases. Thank you very much, guys. Thank you very much.